Um, what happens here is if someone's ammonia levels are high, which is a um, lab indicator that can be drawn, they should be on a low protein diet. Now, not everyone with cirrhosis has high ammonia levels. What's happening here is the liver typically converts protein into amino acids. Okay, that's one of the functions that we saw on the first section of our discussion in liver in the text. When that conversion occurs from protein into amino acids, ammonia is a byproduct, and the abbreviation for ammonia is NH4. The liver converts ammonia into urea, which is excreted by the kidney. But this is not happening in cirrhosis many times or oftentimes. So we see an increase in ammonia levels. And when we see that, the person may need to be on a low protein diet. So think way back to the RDA for protein. You all know it's 0.8 grams per kilogram. For someone with cirrhosis and high ammonia levels, their protein needs may be 0.6 grams per kilogram of body weight. Okay, but again, this is case by case. If someone has cirrhosis and they have normal ammonia levels, we certainly don't want to limit their protein because they do need the calories. But I just want to contrast that hepatitis, high calorie, high protein diet, fat soluble vitamins with cirrhosis, low protein diet only if those ammonia levels are elevated. So next we move into gallbladder disease, and you'll want to pay attention to this section because you have a case study for your homework this week based on gallbladder disease. Just an aside, these two words are two of my favorite words to pronounce in the medical terminology: cholelithiasis and cholecystitis. So cholelithiasis, this lith, that means stone. So that's the presence of stones in the gallbladder. Cholecystitis is inflammation of the gallbladder, okay? There really is no clear reason why some people suffer from gallbladder disease. There are certain risk factors that put us at greater risk for this, and that's being a female, being over the age of 60, being Native American or Hispanic, overweight, obese. Pregnancy increases our risk for gallbladder disease. Someone who consumes a high fat, high cholesterol, low fiber diet, someone with a family history, someone with uncontrolled diabetes, somebody that's taking hormone replacement therapy drugs, and then finally, someone who does a lot of yo-yo dieting or quick weight loss. So greater than 3 pounds a week weight loss, and then maybe gain it back, and then lose it and gain it back. And part of the reason why people have problems with their gallbladder then is that their gallbladder doesn't empty properly. So recall back in chapter 3 when we talked about digestion, the liver is producing bile, which our body needs to help digest fat because fat and water don't mix. They need that bile to work as an emulsifier. And the gallbladder is just the holding point for, or the holding spot for the bile, okay? If the gallbladder is removed, our body miraculously works without it. A person can eat a regular diet slowly after their gallbladder is removed. But if they're suffering from gallstones or the inflammation of the gallbladder, they'll probably be NPO or put on a lower fat diet. And the rationale for that is to decrease the stimulus of that gallbladder having to contract to release the bile. Again, this will be important for you to note in your case study homework for this week. Next, we have pancreatitis, which is the inflammation of the pancreas. Remember back in chapter 3, the pancreas produces enzymes that help us with fat, carbohydrate, and protein digestion. So basically, anytime somebody's eating, their pancreas is triggered. So if there's an inflammation, they're going to have significant pain associated with